Hi. Can't hear you. Can't hear anything. It's just you. Okay. Hello. Watch the birds.
Hi,
Hi.
can you hear me now?
I can.
Yeah, my boob is on the screen.
That's a boob shot. We're gonna keep this PG.
Can he explain? You know the lady we had in 44 that ended up on ECMO? She was on the high intensity insulin,
Catherine's getting right to it.
and I didn't understand. Well, we can keep looking at your boob if you want.
No,
I didn't quite catch. Let me turn my volume up just a smidge.
let me turn mine up too.
I heard something about high insulin, so
Great.
It was the, I don't want to be on screen. The high intensity insulin protocol. It was a drug overdose,
Yeah.
and they were running the high concentration insulin with the D550.
probably say like D20 or something.
Yeah, I don't know. I had no idea what was going on, but I wanted to know what that is like. They were saying that it was like cardio protected, like
The high intensity
Yeah, like you
insulin
treat a
was-
beta blocker overdose,
Yeah.
but I don't know.
Yeah.
As you can tell, I didn't understand enough to even ask the question.
Yeah, sure. Hi. Oh, maybe we'll get a dietary question soon too. So,
Clinical nutrition, he says.
clinical nutrition.
I'm just giving you. You can. I'll be here for a minute. I'll answer any dietary questions.
Oh, I might have my own question.
Oh, I don't need. Why are you putting it on me?
I don't know, because I'm eating.
So am I.
Oh.
So with beta blockers, calcium channel blockers, especially like the beta blockers, there is a way to sort of like an antidote, as I might call it. I don't know if that would be the technical name, but when you have somebody who is beta blocked, obviously I would say the primary way of stimulating the heart is through beta stimulation, so beta 1, beta adrenergic. And with that, you obviously get an increase in heart rate, you get an increase in contractility. I think of this scenario, the best analogy I came up with a long time ago when I had my first one, which was like, you know, a little bit sphincter puckering, because you're like, oh, is kind of like a house, right? So think of the cells in the heart as a house. And normally you would go through the front door to get in and out of the house. So I think of that as like your beta receptor. So naturally, if you secreted your own epinephrine or norepinephrine, you would have stimulation to the beta receptor, that beta 1, which would obviously increase your heart rate, then increase contractility. But with beta blockage, obviously, you're inhibiting that mechanism. So think about like your front door being the beta receptor, and let's say you need to work on your front door. So you can't get in and out of your house through the front door. So naturally, most houses, I would say, and maybe not all, have a back door. So there's another way to get into the house. And so how I think of it, and there might be more to this, but from the best way I can describe this is that if you take a little bit of like an overdose on a little bit of beta blocker, the antidote would be glucagon. So you're injecting a hormone that is going to stimulate gluconeogenesis to your liver, and then it's going to increase the amount of sugar that's released into your bloodstream.
Paul's
And
getting
therefore-
excited.
What's that?
Paul's getting excited. Gluconeogenesis is what, you know.
Yeah. So you stimulate gluconeogenesis, you release all this sugar into your bloodstream, and so what then is stimulated after that, the next mechanism would be your pancreas saying, here's a bunch of insulin. And when you do that, your insulin is going to shove your glucose into the cells. So there is energy getting into that cell, therefore the cell can still work. I'm just going to put you on mute for a second. If you have a question, just unmute. It's hard to, like, sometimes I'm getting thrown off with the bells. But so when you increase the amount of sugar, you're going to increase the insulin. Insulin is going to start pushing the sugar into the cell. And so I think of that as the backdoor mechanism. So to get energy into that cell so that the cell can actually function is to shove sugar. Think about like those kids with a candy bar. As soon as you give them a candy bar, the sugar is like, they can do their thing. So if you can't walk through the front door, which is your beta receptor, then another way is to go through the back door, and that is to just push sugar into the cell. And there's probably some other mechanisms going on that I'm unfamiliar with, but you've actually introduced the energy that it needs to function, so now the cells can still do their job. And so you're going to need a lot of sugar until the beta, the drug that you've ingested or whatever, has sort of worn off. So that's the primary way that I can think of this. Like I said, with insulin, there might be some other mechanisms intracellularly that I don't know anything about, But the best way I can describe it is the back doorway. So when you have the insulin going into the cells, obviously you need a lot of sugar. Otherwise, you're going to bottom the patient out. So these are the patients. It's kind of scary because you're running 600 units an hour. You're probably given in 1 hour more insulin to one patient than you have collectively to all the patients you've ever done in your entire career, which is very scary. But as the drug that you've ingested, whether it's the calcium channel blocker or like in this case we're talking about beta blocker, if you as that drug sort of wears off, then obviously you don't need as much and you can wean these things down. So interesting enough, you still try to stimulate those receptors. So you still try to, use your Levophed usually for beta stimulation, but also alpha, right? Alpha 1, so we're constricting blood vessels. So peripherally, if we're losing our blood pressure because our heart isn't pumping forward and our cardiac output's down, we're trying to tighten up the pipes distally, but then we're still trying to get and stimulate the heart to beat. So if I can't do it through beta, which I'm still introducing beta through Levophed, then that backdoor mechanism should hopefully increase the heart rate. So when I had my first patient, it was kind of like, you had Levophed running, but if the blood pressure decreased, it wasn't go up on your Levophed, it was actually go up on your insulin drip. So weirdly enough, this is the one time that you use insulin like a vasoactive. It's an odd thing. And it's obviously not just heart cells, you're shoving glucose into every cell in the body, right? So you jack up your D20 drip or whatever drip you're using to then offset so you can utilize your insulin to stimulate the heart to beat. Boom, boom, boom. That's the best way I've ever been able to sort of sort that out in my brain and think about that. So
I was just explaining to Kate what you were talking about. So basically, you're just stimulating the cells to continue to flush those toxins out by using glucose and insulin.
I wouldn't say flushing toxins out. It's just that there's the overdose is just that there's a drug present that obviously like the lock and key, right? It's in the way of the beta receptor or the beta receptor, and so therefore that drug, or sorry, let me back up. The drug is preventing your own norepinephrine or epinephrine from stimulating the heart to contract, to beat. So this is again that backdoor mechanism, but it's not because they've been quote unquote poisoned. It's more just that they're just non-functional because the front door is being blocked. So let's go through the back door and stimulate it that way. So now we're going to push glucose in so the cell has fuel, right? And then it can generate and make ATP. The mitochondria can do their thing, work, function. And I don't, is the insulin also doing some other things intracellularly that cause the heart? I mean, other than glucose being a fuel, I don't know if insulin has another purpose. This would be a good pharmacology question that I don't know, I can't answer. But if you were to look, does insulin promote a cascade of events that when it's present, right? But if you think about very low dose, I mean, if you're in the ICU doing that protocol, they've usually ingested an enormous amount of something, whether it be low pressure, extended release, it's, already through their stomach and it's somewhere in the middle of them. So you're not going to be able to get it out and make them vomit. So now you have to let it pass. So yeah, you're going to need big doses of these things. But if someone took, like 10 low pressure and showed up in the ED, usually they're just going to take a little bit of glucagon and inject that, right? And then that hormone will stimulate your liver to release glucose into the bloodstream, and then therefore your pancreas should respond and then shove that glucose intracellularly. So that's like, it's like taking that idea of glucagon and like turning it into something really, really big, right? Because if you think about it, all glucagon's doing is presenting more sugar in your bloodstream, and then you have insulin to push it in. Now what you're doing is you're infusing a bunch of glucose and you're infusing a bunch of insulin to shove it into the cells. And then again, all cells, not, I mean, we're talking about the heart, right? Because we're thinking about beat, 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 but remember, this is all cells in the body. It's not just like, you know, thinking of the heart when you infuse these things. So all the cells. So I would be, I mean, I wouldn't say you might have this patient together, but this is just out of like thinking, where you work, obviously, if a patient were to, let's say, ingest a bunch of one of these types of drugs and then slip and fall and have a head bleed, you know, that's a tricky one, because you don't want to shove a bunch of sugar into their brain because that's going to bring water, but also you need to do that, you know, at the same time, because that's what's going to help with that ingestion of that drug. So that'd be a really interesting person, a hard one to take care of, I think, because you'd be dealing with maybe high ICPs, but also trying to keep their heart beating, you know? That'd be a really interesting patient to try to take care of.
It doesn't work to say that.
Ellie says if the heart's not beating, then you're brain dead.
Well, true.
ABCs.
Yeah, no, true. I'm just thinking of trying to juggle both of them, you know? It seems like this one might need his skull just removed, just in
You
case.
know, we're gonna like drive up here.
Yeah.
We're the only ones on, huh?
Well, you know, Karen Barnes popped on for like a second, and then she like left, and I don't know if it's because she had trouble signing in, and I was just hanging out with Jackie for a little bit, and I just kind of gave it a little extra time just to see, because I know some people, I've told people, you know, pop in whenever, if you want to pop in for 30 minutes, ask a question and leave. This isn't that, you know, here at 9 and stay the whole time. So.
Sitting across from my patient who I'm lightening her sedation, so I might jet off.
That's okay. Yeah.
Are you at a stationary computer?
Yeah, I'm at my desktop.
I want to see your landscaping that you did.
Oh no, I haven't done anything.
Oh, I thought you were telling me you did a bunch of gardening on your vacation.
I wanted to, and it went. You know what happened? Well, I don't even know where he is, but I got a cat.
Oh. Yep.
Yeah.
A kitten or a cat?
No, I got a rescue 1-year-old. His name's Sammy, and he likes the birds. I can see if he's over here. Hold on.
Cat for us. That must be the dining room.
My cat's name's Sammy. Samarella.
My cat's name is Cat.
Cat. Can Owen name him?
Owen named him Brody, but we just call him Cat.
He's probably tucked away somewhere sleeping now. He had his like breakfasty lunch. Yeah.
What color is he?
He's black and white. He's a tuxedo cat,
That's what I have.
and he's a very good boy.
Is he going to go outside?
No. I mean, the busy road and having like fox and stuff. I don't know. I just feel like
You have another cat too, or is this?
no. This is the first pet I've ever owned.
I was going to say.
I want a dog, but I just don't think it's a fair life if I'm gone, you know, for 14 hours, 15 hours a day. So I thought a cat would be the next best thing. The only thing I don't like is hair, but this guy's not too bad, and I bought this brush.
Is he long haired?
No, he's medium, I guess, maybe.
That's what I have.
I think. Nobody.
Do you have any questions for me?
I bought him
I don't
a
think I-
perch right next to me. He loves it. He watches
My
the birds.
thing is,
I can't think of any questions for you except that I want a tour of your house and your yard.
Maybe by the end.
This is stationary. It won't go anywhere. The best I can show you is the hummingbird feeder. By the way, we have hummingbirds. They're back. So
This just came in this week too.
yes, I'm happy about it. I love the hummingbirds.
Do you have any questions? Is your house in Buxton?
Yeah.
Yeah.
Yep. Did I answer the question for her?
You had to leave.
Yeah.
Rounds started.
Okay. I mean, it's recorded anyway, so I can post it, and then if she needs to, she can come back to it. So. Oh, here he is. He must have. Were your ears burning?
Oh, the kitty!
Were your ears burning?
Come here, Sammy.
They want you to be famous.
Oh,
Sammy.
goodness.
So cute.
Look.
He's
He's like, look at those eyes.
You want to see the
Yeah, huh?
birds?
It's cute. Because I want those hummingbirds.
He's very, very gentle. Here, I'll show you.
Oh, he even has a little
He has a
seat.
I bought him. Yeah, I bought him a window seat,
That's cute.
Right
You
at the
get-
bird.
and he gets to
Oh,
watch
yeah.
the birds.
Oh, he's cute.
He is cute.
Yeah, he's wicked.
He's settling right in.
Yeah, I guess you call
How
that.
did you pick that cat out of all the cats?
Interesting story. My sister came to visit, and I had been kind of thinking about getting a cat for a while. Oops. And she went on the Animal Refuge, the website, and they happened to have, obviously, this cat, and his name is Monty, and our old dog that passed away in 15, his name was Monty, and he was like our best, like our favorite dog. He was so good. Well, I mean, one of our favorites. They're all our favorite. But he was such a good boy. And then my Charlie, his dad passed away. Oh, here we go. I'm just walking by. His dad passed away in 16, and the day my sister went online and sort of saw him on the website, his name was Monty, and she found him on April 24th, and that's his father's birthday.
Oh,
And so between the name and like the date was kind of symbolic. So
it was meant to be,
So how come you named him Sammy?
right?
Monty just didn't like seem like it fit, so we renamed him Samuel Montgomery Herbst.
Oh my
SMH, shaking my head. So, but he's really good, really very gentle. So
Did he sleep in your bed last night?
he sleeps every now and then. Yeah,
In your bed with you?
sometimes. Yeah, sometimes I guess he'll just crawl around. I'll wake up and I'll be like, "What is walking on top of me?" And it's like, "Hi." So
22 almost bigger.
Uh-oh.
Going to a head sleepy.
Right now?
Wait, a plant one? No, I guess he's sleepier. So they were trying to say pivot him back to bed. It's in the chair.
Oh.
do you guys have any other?
You okay? And they're like, yeah. And
I was
turned
just
around
trying
and
to
she's
think
like,
of some.
It's all right.
I thought I'd be listening to other people asking questions. I didn't know if it would be.
Oh yeah,
Hey,
no,
honey.
it's fine. It's fine. It's kind of funny though. The last one I did, it was a very similar experience. No one showed up for a while, and then right before I camered out, SKU2 logged on, COVID SKU2, and I think it was Corey and Christina. I know there were other people there. I can't remember who. And we just had like a little discussion, I think, about like antibiotics and stuff. So that was good. It was just like a 30-minute interaction. But so no, if there are no other questions, that's no problem. You guys can camera out, and I don't think anybody else would be coming, but if they do, they do. If not,
Well, I'm glad you're doing this.
Yeah.
Wish
Yeah.
I was not and had my,
I wish I didn't miss my question.
No, that's okay. You know what I tell people, you know, and it's for anybody, obviously, is if you have like something that you keep on you, usually at work, and you think of a question, I usually just say like write it down so that if you come to one, then you like, you know, you'll remember. You can pull
Not good, not good.
it out of your pocket.
well, thanks, Mark.
Thank you, Mark.
Yeah, you're welcome. Hope
Have a good day.
I could have answered it well.
I'm going to try to repeat what you said to Catherine.
Yeah, and I'll upload this so that she, you know, she or anybody obviously can watch it.
Great.
And you know, the next time I see one of the our super awesome pharmacists, I will ask him if there's more to the insulin too, like if there's another aspect of insulin that happens intracellularly that creates this cascade of energy as well. Mine, you know, not just like having glucose present, but are there other cellular processes that are occurring also, not just the presence of glucose, but the best thing I
And
can think of.
do you ever see this insulin infusion, this high intensity insulin infusion on other types of overdoses other than beta blocker?
Hers was Effexor and hydroxyzine.
Her overdose was Effexor and hydroxyzine.
The only thing I've been a part of, and I've only had a couple since in the last, I don't even know how many years, was beta blockage and calcium channel blockage. Hydroxyzine is like antihistamine, and Effexor, trying to think, I don't know like the pharmacokinetics of these drugs.
Yeah. I think it's an SSRI.
It's an SSRI they're thinking.
Yeah, I'm just trying to think of.
That's what I didn't understand too.
So,
Why that?
Yeah.
No, because usually it's the opposite. I was just trying to think of like serotonin syndrome, but it's usually I think when you wean it away, you know. And that's usually, I believe, tachycardia. I can't really remember. I'd have to look that one up.
Were you here?
But and there wasn't some sort of blocker or antihypertensive. No. Effexor and hydroxyzine. Right, I heard you right. Hydroxyzine. Okay. That's like the old-fashioned antihistamine. Makes people super sleepy. People can use it for sleep.
Yeah. She did well, right? I mean, she's crazy. That's the
I
one
think that was a
with
great
30, right?
thing.
I moved her out, and then I think she co-grade twice. Moved her out for this one.
She went to CTIC for ECMO.
Yeah, she was cannulated. But I think she was tachycardic. You know, like that's what I was confused about.
So they were
When they-
using this protocol for somebody who's already tachycardic?
Yeah,
That one I don't know.
retacking.
And what was your like insulin dose? Was it in the hundreds?
I think we started at 70.
So not like the beta blockers where usually I see like
No,
400,
like
500,
700.
600. Yeah, this
I think I
is
bolused her at 70 and then.
Yeah, like the calcium channel blockers or beta blockers will have an insulin infusion at 700 an hour.
She wasn't mine, but I was trying to help out. And when I went to like hang the insulin and give the bolus, I like pooped myself a little and I was like, I can't.
sphincter puckering. Got it. This one I would have to punt to the pharmacist because I'm not sure those drugs specifically and why you would need
I already did.
that dose.
I didn't understand any of it, which is why it wasn't my patient, which is probably part of it too. I was just helping.
Okay.
And then she went down for ECMO.
I wonder, you know, this is the thing. It's like, okay, you take an SSRI for depression or for, you know, anxiety or whatever, or all of the above. But taking too much, I don't know how what that does, like what are the other cascades that could occur from those, that drug or hydroxyzine. I mean, we never give that.
Right.
It's like, very uncommon, I guess. There must be like, if you take so much, this is one of the side effects that you might get, and therefore requiring this as the treatment. But I just trying to think about the drug, but I really don't know enough about each of those drugs.
I think it was kind of like a Hail Mary because they were saying effects there's no, like, the things she took, there wasn't any antidote. Typically.
Dialysis didn't happen?
I wonder if it makes, was she diabetic at all?
That I don't know. Actually,
just
no.
throwing out an idea. I wonder, does the drug make you hypermetabolic and therefore you need the sugar, like this immense amount of sugar, because somehow your metabolism is like super revved up, so you're chewing through your sugar. But maybe she's a diabetic and needs insulin to then push it in, and that's why it was a lower dose. Just an educated guess here. I don't know, but
I wish I knew more about her.
Yeah, that's an interesting one. If I'll definitely try to ask one of the pharmacists. But if you run into one today, I would maybe ask that question, because that's an interesting one. The only thing I've ever used this high insulin and glucose or dextrose protocol is for a beta blocker overdose or the calcium channel blocker. Calcium channel blocker overdose. So
yeah,
I'm
and
not
that was
familiar.
how they explained it to me. Was like that's what it was for, but I didn't understand how it fit that situation at all.
Okay.
It sounds like you don't either, so that makes me feel better.
And is there a time frame that this might seem like a dumb question, but how do you know when it's time to turn down the insulin infusion, and like how do you know when that overdose is it just the half-life and you're going by that? Or is it
I think
something
that plays a
clinically?
factor into it. When I took care of my last, the protocol was being developed, and so I don't know what strategy they're using right now, but basically if I remember, I think that you used these two agents in conjunction, obviously with like a Levophed, right? And what you would try to do is wean off the Levophed first, and then if they maintain heart rate and blood pressure, then it was like a percentage. So it might be go from like, let's say you were at 400 or 600, then you might go to 550 and or even 500, and then you would keep checking your blood sugars, and then if your blood sugar went up and your heart rate and blood pressure stayed okay, then you would wean the dextrose strip. Okay, then if your blood sugar and everything stayed okay in all of those components, then you would wean the insulin again, because the insulin is obviously driving in the sugar. So if the sugar stayed high, your insulin was down, but blood pressure and heart rate stayed okay, then you could wean the dextrose strip again. And then it was just like staggering it like that, little by little. And so I believe, again, not knowing this protocol off the top of my head, but if you, it was like a percentage, I believe. So you would just wean a certain amount of insulin, check all of those values, if all of those things are okay, heart rate, blood pressure, and then obviously your glucose was up because you're obviously less insulin, then you would wean the dextrose, see if everything stayed okay, then just boom, boom, boom. But I want to say, if I'm not mistaken, I could be wrong on this, but I think you wean your Levophed first. You want to try to get rid of the Levophed drip first. And then you start working on the insulin and the dextrose. But I'm not 100% sure, but that's what's in my brain right now. So. Yeah.
Well, thank you, Mark. I'm just going to leave it on. I don't know if the girls wanted. I'm going to go lighten my patient rounds.
That's okay. If nobody has any questions, I'll just camera off. But if anybody else is there.
Good. Yep. Thank you, Mark.
You're welcome.
Thanks. Have a good day.
You too. Bye,
Bye.
guys. Have a good shift.
Bye. Thanks.
Bye.